There's a couple different things that are different for cardiac patients versus respiratory patients that I talked about earlier. A lot of these patients are failure to thrive. Does anyone imagine why?
Oxygen, energy.
Okay, not being enough oxygen. Why? What else? The heart's working overtime. There's a lot of cardiac demand going on, and so some of these kids are failure to thrive because they're burning a lot more extra calories to pump the blood through their body system. Obviously, we're going to have some conditions that we're going to talk about that can cause cyanosis, some that do not cause cyanosis, which are a little bit harder to assess and realize they've got some heart problems. We can have chest deformities because over the years, as the child grows, they may learn how to breathe a certain way due to their heart condition. There's different conditions where the heart may not be on the left side of the body, but on the right side of the body, and that can cause some chest deformity as well. We can have different pulses from weak and thready to strong and bounding, depending on their heart condition. Obviously, the cardiac system and the respiratory system go hand in hand. They're so tightly connected that we're going to have a lot of respiratory symptoms. Just like when you think of adults with CHF, similar with these kind of conditions. Also, when we auscultate, there may or may not be a murmur, depending on where the defect is and what's going on. They can have additional S3, S4 sounds. Bradycardia, and this last picture down here is of the clubbing. You guys remember from respiratory what clubbing? What causes clubbing? I hear decreased oxygen, that's correct. There's several different diagnostic tests that we can do when we suspect that someone has a heart condition. First we're going to talk about an electrocardiogram. That's just what it sounds like. It's looking at the electrical activity of the heart. It's the typical rhythm strip that you think of. A lot of times patients will be put on this Holter monitor, and that's a 24-hour continuous recording. It's something they can actually carry around with them underneath their shirt or in their jeans pocket. People don't really know what's going on. It doesn't feel like they're sticking out from the norm by wearing their monitor, but that's just going to measure the electrical activity for a good 24 hours so doctors can see what's going on. The patient doesn't have to be hospitalized and hooked up to a monitor for 24 hours. They can actually go on about their business. The other one is an echo, and that's just using the high-frequency sound waves, similar to what they do at prenatal visits when they do ultrasounds. In order to detect a lot of these heart conditions, they can find them as early as 16 weeks, and that's usually a prenatal diagnosis, and such as congenital heart disease. There's also what they call Doppler, and that's more, I don't know if you guys remember from OB, if you've seen this yet, it's a handheld device, and we can also use those to find patients that have very weak pulses or arteries to do venous punctures. That's very helpful. There's also what's called a transesophageal echo, and that's basically where they're just what it sounds like. They're going down through the mouth, through the esophagus, and you can see the back side of the heart, the posterior side of the heart. And that is helpful when we start talking about coarctation of the aorta. That way you can look at the entire aorta, the descending aorta on the back of the heart by using this transesophageal echo. Alright, so similar to adults, we can do cardiac caths on kids. And that's just putting a radiopaque catheter, and that's usually inserted through a peripheral blood vessel. They really like the femoral artery. And then they go up into the heart, they inject contrast dye, and they're looking at the different pressures and oxygen levels inside the heart. And they're also trying to visualize the blood flow, seeing if there's any kind of stricture in the coronary arteries or any of the major arteries that are supplying blood to the heart. There's such thing as diagnostic casts and interventional casts. Interventional casts are those ones that we think about where they go in and they stick the balloon and they dilate in order to put a stent. They're trying to open up some of those vessels that may have strictures. So we as nurses, when we have patients that come back from cardiac casts, which we've experienced, our group has an inpatient clinical, what's the main thing you want to be most concerned about after a cardiac cath as a nurse? Bleeding, hemorrhaging, right? And what's the second thing? We constantly check on as soon as they get back. I'm sorry? Pulses and oxygen. So we want to, if they went in the right leg, then we want to constantly be checking the pedal pulses, and if you can feel the popliteal pulses, to make sure that we haven't caused any kind of major obstruction. We also want to feel, is it warm, is it cool, is the skin shiny, is it tight? Looking to see if there's any kind of occlusion there. Good ways to assess if there's hemorrhaging, obviously we're gonna look at the dressing for blood loss, also infection. And we wanna encourage kids, which is kind of difficult, to keep that extremity straight for 4 to 6 hours. Sometimes the complications from this procedure, because we are putting contrast dye into their system and up towards their heart, they can have transient dysrhythmias as a result of that. Very rarely do they have serious complications like strokes or seizures from this. There's usually something else going on if they've had a hard cardiac cath. Alright, so which of the following procedures uses high-frequency sound waves obtained by a transducer to produce an image of the cardiac structures? A, B, C, or D? Anybody remember? We just saw it on a couple slides back. It's high-frequency sound waves.
A.
A, that's correct. Alright, so now we're going to start getting into some of the defects. And something that I want you guys to keep straight in your minds so that we can understand how blood is being shunted or pumped through the heart is we need to remember that the left side of the heart is the strongest, specifically the left ventricle. And why is that? Do we know? Thickest wall, and it's also the one responsible for pushing the blood out to the heart, the rest of the body. So that's why it's going to be the strongest. So when we think about pressures and we talk about pressure gradients over the next little while, we want to think about left ventricle is the strongest. So in there's a hole anywhere, we got to think, where is the left ventricle pushing this blood? So we mentioned earlier on that cardiac assessment page that we can have patients that present with cyanosis or they can be acyanotic. Obviously, cyanosis is that they are not receiving enough oxygen, so they're going to have some paleness, maybe blue if they've been prolonged decreased oxygen. So examples of this that we're going to talk about are the tetralogy of Fallot, transposition of the great arteries, and hypoplastic left heart. However, there can also be patients that present with acyanosis, meaning you don't really understand what's going on. Maybe they're having some oxygen issues, and your first thought is respiratory, but they're not presenting with this pale or blue skin. They just have maybe low oxygen levels, and they're remaining pink. And those are the ones that we're going to talk about in just a few minutes: the ASD, ESD, PDA, and the COARC. So when we talk about conditions where patients are cyanotic, this is because they have decreased pulmonary blood flow. And I wrote over here on the board so we can keep these things straight in our head as well. An example of decreased pulmonary blood flow would be tetralogy of Fallot. Might want to write this down somewhere to keep it straight in your mind as well. Conditions where the blood is going to be mixed, meaning that first picture where we saw the blue blood and the red blood because it was oxygenated and unoxygenated. This is a mixing, so we're going to get purple when we look at these pictures. So examples of mixed blood flow would be transposition of the great arteries and hypoplastic left heart. So acyanotic heart defects, meaning they are still pink, means that we have increased pulmonary blood flow. Your book likes to call it increased pulmonary congestion, but it basically means increased pulmonary blood flow. And those examples are ASD, VSD, which are defects in the atria and the ventricles, and then a PDA. And then an example where blood is completely obstructed from the ventricles, we'll talk about a COARC and different kinds of stenosis. The first one we're going to talk about is called atrial septal defect, which gives it away. The defect is going to be in the atria. It's between the right and left, so that's going to cause a shunt of blood from left to right, because again, the left side is the strongest. That's where all the pressure is. As a result of this, we're going to have high pulmonary resistance. As we've already written on the board, we have high or increased pulmonary blood flow. So let's look at this picture so we get this straight in our mind what an ASD is. So on your little piece of paper that I passed out with all the hearts, you might want to draw this in exactly where the defect is. It's right between the two atria. I'll let you guys write that down for a minute. We'll talk about it. obviously from this picture, the left side of the heart is the strongest, so it's pushing the blood through the defect between the atrias into the right atrium. So this blood is going to be unoxygenated, the blue, plus the oxygenated, that's the red, and we're going to get purple, meaning a mixed blood that's going to go into the right ventricles. Yes.
I don't really understand what you're supposed to do on our heart.
It's for your own benefit if you want to.
No, I want to draw it.
Okay, so just, if I were you and I had a heart, the normal size heart, I would circle in between my atrias and label it as ASD. And then I might also show that blood is being mixed down here in the right ventricle. So this is why we say that an ASD over here on the board is increased pulmonary blood flow, because we have oxygenated and unoxygenated blood mixing into the right ventricle and going up through the pulmonary artery to the lungs. So we're going to have increased pulmonary congestion or increased pulmonary blood flow. Kind of makes sense? Not really. So this is why these patients do not look blue, because they are still, this mixed blood is still going to go out to the lungs and get oxygenated and come back in the left atrium. So they're not blue and pale. Yes.
So does blood not go from the right atrium to the left atrium, only from the left atrium to the right?
Right, and why is that again? Remember that big powerhouse picture? Left side's the strongest, so it's going to push all that pressure this way. That's why it's coming through the defect this direction. And that's why that first slide we just saw a second ago is we have a left to right shunt. So the left side is the strongest. It's going to push everything through that defect. So like we just said, since these patients have that mixed blood but it's going out to the lungs to get oxygenated, they're not going to look pale, they're not going to look blue. They may even be asymptomatic. We may have to look underneath an echo to see that they have a hole between their atrias. However, they could have a murmur. They may present with some CHF because they have this increased pulmonary blood flow. They could have atrial dysrhythmias because the atrias with this defect are not going to pump correctly. So in order to treat this, we can place a surgical patch called a Dacron or a pericardial patch. And this is only if these patients have moderate to large defects. If it's a small ASD, they're going to see if the infant can grow out of it with time. They can also do open heart surgery if it's a large defect, and that will require the pulmonary bypass machine. And that's usually they're going to wait till the child reaches school age. They're going to try the patch as long as possible. And if they have to go in there, if it's a large defect, they'll go in and do open heart surgery. The next one we're going to talk about is a VSD, which again in the name gives it away. It's a defect between the ventricles. Same thing with the ASD. We're going to have a shunt that goes left to right because left side of the heart has all the pressure. It's the strongest. So let's take a picture, look at the picture of this and write it down. You can see the defect is right here between the ventricles. And again, the left side is the strongest, so it's pushing all that already oxygenated blood back into the right ventricle. And it's mixing. Yes.
So the blood's flowing backwards, like it's already been in the left ventricle. It's like regurgitation almost, kind of.
Let's not use regurgitation.
Right. No,
yes,
I know.
With that thought.
Okay.
Right. So it's going to be mixed over here and go out the pulmonary artery, go back to the lungs, and get oxygenated. We do still have blood that's going up this way as well, out the aorta to the body. That's why these patients aren't looking blue because they're still getting oxygenated blood out to their body. So you can see how it would be easy for this right ventricle to have an increased cardiac demand because it's doing all the work right here. It's getting all the blood from the right atrium, and then it's got the left ventricle pushing all this blood into it too. So it's working overtime. So since the left side is the strongest, we call this a left to right shunt.